Okay, everyone, welcome to Chapter 3. This is where we're going to do a quick overview of emergency moves for moving our patients and how to properly prepare ourselves for those moves to prevent injury and things like that. It's lifting and moving patients for Chapter 3. Again, my name is Michael Purdy. Your instructor for this class, nationally certified paramedic in North and South Carolina state certifications as well. Volunteer in fire and rescue departments in Western North and South Carolina, and got my hands in a little bit of everything. So do remember, if you have any questions or any notes, anything that you want more clarification on, make some notes, write those questions down. When we meet in the classroom, we'll have a session for review at the beginning of each class. Bring those questions up and we'll talk about them in a group. And then also keep in mind these movements and most of these movements and procedures we will be going over in person, so you can actually practice them and the application of these moves. So we do kind of jump back a little bit and build off of Chapter 2, the Workforce and Safety and Wellness chapter. We'll talk a little bit about our standard safety precautions, PPE, stress management, and then prevention and response of related injuries, and then, of course, lifting and moving patients. So as an EMR, we must be able to analyze an emergency situation. We need to quickly evaluate the patient's condition. We need to ascertain or discern, is this an emergent situation? Are they critical, not critical? Do we have time to stay, stabilize, and play, or do we need to get them out of the situation immediately? Is this a life or death situation? A really good example of that would be a wrecked vehicle on a live railroad track with a train barreling down on that car. This would be an immediate extrication or rapid extrication scenario. And then we also need to be competent in carrying out effective life-saving emergency medical procedures. That can include, and this can include, lifting and moving or even positioning a patient and assisting other EMS providers. If we have a victim that is entrapped somewhere, simply positioning their airway or restoring blood flow to an extremity or something of that nature can be very beneficial to that victim. In some cases, your knowledge of emergency movement techniques may help save a patient's life. For example, getting them out of a burning car or opening their airway for them, things like that. For unconscious patients who you don't have a suspicion of traumatic injury, we want to put them in what is a position that is known as the recovery position. This is where they will be laying left laterally recumbent or laying on their left side. And you can see here in this picture a demonstration where they've got their right knees kind of canted out in front of them to support their body from rolling all the way over onto their belly, or where they would be prone. And then they have their right arm is tucked up underneath their face to keep their mouth and their nose, their airway out of the dirt, carpet, leaves, what have you. And then this position also allows for secretions or vomit to drain out of their mouth or out of their airway and onto the ground. And then, of course, the left arm is kind of out in front to help support the upper portion of their torso from rolling down as well. This is also an effective and useful position for women who are pregnant because it alleviates pressure on the superior vena cava and allowing blood flow to circulate more adequately through the body. Every time you move a patient, keep general guidelines in mind. We don't want to do any further harm to this patient. We want to move the patient as minimally as possible and only when necessary. Every time we move the patient, we need to consider that that's kind of opening up the door for potential injury or further harm. So we want to think through our moves before doing or conducting a move and think to ourselves, is this actually going to benefit or improve the overall situation for the patient, or do I have a potential of actually making it worse, and we're just trying this move to see what happens. So we want to do this as decisively and efficiently as possible. Also, we want to move our patient's body as a unit. We don't want to go feet first, head later, or vice versa. We want to go entire patient from A to B in one move. So communicating with your partners if you have multiple responders and making sure everyone's on the same page before initiating that move is important. We want to use the proper lifting and moving techniques to ensure our safety, just in case anyone's wondering. That is short and quick, stiff movements from the waist up. That is not it. It is using your lower legs and keeping your back in alignment to support your frame so that you don't actually have those twisting torsion movements where you actually do pull your back out. So we're going to have one rescuer give the commands when moving the patient. The head and the airway are pretty important, so I typically will tell the group, I say, okay, the head has the call, or whoever has control of C-spine or the patient's head is the one that's going to call the shots on when to move and how to move the patient. Some other recommendations, especially as a first responder or emergency medical responder, sometimes just delaying the movement of the patient, if it's possible, until EMS arrives or just additional personnel. That just kind of eliminates unessential movement for that patient, especially if we have things like broken bones or other types of trauma, where every time we move that patient is causing them pain. Treat the patient before moving him or her unless it is unsafe. So if the situation as a whole is somewhat safe, but they have an airway issue, we want to take care of that airway first. If they cut their leg with a chainsaw, we want to stop that bleed before we move them, unless there is a situation causing that is a greater threat to their life or your own. And then always keep your patient informed. You know, they are an equal contributor, participant in this situation. So they need and deserve to know what you are doing to their body before you do it. Talk them through it. If you think that it's going to cause them a temporary amount of pain, go ahead and let them know. It's like, hey, we need to move you away from this active beehive. It's going to hurt, but we're going to do it, especially if they're allergic to bees. So talk to them, get their consent before you do things as well. If you're going to assess a broken extremity or even just simply touch someone, go ahead and just make sure it's okay with them. You know, I need to assess your pulses in your feet or in your lower extremities. Is that okay if I do that? And if they have any kind of awareness, cognitive awareness, they should be able to tell you yes or no. And if they say no, respect that and maybe circle back around and try again later. Or decide for yourself, is this actually critically necessary for me to assess at this time? Keep the rules of good body mechanics in mind. Know what you are physically capable of and not capable of. And if you don't know that, use a training session with your agency to find that out. Or go out on your own to go to a gym and find out what you are capable of and where your limits are. You want to keep your feet and your shoulders at a broader stance. You want to stand in a triangular fashion to give you better stability and maintain your balance and firm footing. Maintain the natural curve of your spine and don't bend at the waist like I joked about just a moment ago. You want to keep that as in line as possible for the stability. Using your leg muscles to lift, those are some of your biggest muscles in your body and the strongest, and that's where you're going to get the most energy efficiency from. And then try to keep your arms close to your body for strength and balance. If we're reaching way out across a patient's bed or reaching into a hard to get place, we're already putting ourselves at a disadvantage because we're out of balance, and that's our weakest point. Avoid twisting your body when carrying a patient like this. That automatically puts one side of your body in an extreme amount of tension where the other side is at a lax point, and it ends up trying to compensate for itself, increasing the probability of injury. And then, of course, going back, don't move your patients any more times than is necessary. So doing all this improperly can result in injury to yourself, which is the least desirable, but also injury to your patient, which is also very undesirable as well. We want to keep our back straight as we lift, keep our shoulders spread apart, keep our arms in close to our body, and use those strong muscles with the lifting. Get a general idea of how much your patient's going to weigh, how many people you might need. If it's just you and a partner, look at the patient and decide whether or not you can do it, just the two of you, or if you need 4 or 5 or 6 people. And then also a consideration is how far do we need to move this patient? Is it just from the bed to the stretcher, or from the couch to the floor, things of that nature? Or do we actually have to go all the way through the house, down the front steps, and halfway down the driveway? Knowing your physical limitations, remember that. Find out what they are if you don't already know them. And then never hesitate to call for additional resources. If you have too many coming, that's fine. You can get to a point where you realize, oh, we don't need you anymore. You can go back in service. Thanks for coming. It's much better to have too many coming than not enough. Usually by the time that you realize you don't have enough resources on hand, you are already extremely far behind the 8 ball, and you're actually getting yourself into a pickle, or you are in a pickle. You're just now realizing that you are. And then also in training sessions, practice these moves with your coworkers, the people that you're going to be responding to calls with. Practice these types of moves and communicate. Practice communication. Later on during this class, when we go over communications, that'll be a very big deal. It's very important to have clear, concise communications with your team members. So some of those situations where we need to move, those life over limb kind of situations, some examples there is danger of fire or explosion. The patient may be in immediate danger of drowning, or an imminent structural collapse exists, or high probability of an imminent or immediate structural collapse. Hazardous materials that are present, leaking or mixing together, causing toxic fumes. The emergency scene cannot be protected any longer, or never was able to be protected. It is otherwise impossible to gain access to the patient or to other patients who need life-saving intervention or care. So you can't physically get past this less critical patient without moving them to get to that more critical patient. Or the patient has experienced cardiac arrest. The prime example for that is a patient that's sitting in the driver's seat of a car, or any seat of a car, and goes into cardiac arrest. We cannot perform adequate CPR on a patient that is sitting in a chair. They have to be on the floor on a hard surface for any chest compressions to be effective at all. We're just going to go over some of these emergency drags or movements. Sorry, that's just the title of this slide, emergency movements. Some of these you may never use. Some of them seem kind of silly, but they are just different options for you to take into consideration. So emergency drags we have here, you see the clothes drag. This is the simplest way to move a patient. You grasp their clothing around the neck or the shoulders, and as you can see in this picture here, they're demonstrating the use of the forearms to kind of help support the head and the neck and stabilize as they're dragging that patient out. If a room in which you find the patient is not large enough to adequately work that patient, especially in cardiac patients or cardiac arrest patients, you can use this to quick and short movement to get them from between the bed and the wall, or get them out of a bathroom to a larger area where you can actually access your patient and treat them effectively. Remember, in the event of cardiac arrest, it's not a 1 or 2 person job. It's going to require multiple people. Even with the LifeArm or the Lucas devices nowadays, those are great devices that take the place of manual CPR, but they can't be used first in. You have to do manual CPR first before you can apply those. So you still have to access your patient and get them to an area that you can work on them. Here's an example of the blanket drag. You can use this drag if a patient is not dressed or is dressed in clothing that could tear very easily, or if you have to remove their clothing for some reason. You place a rug on the floor or a blanket, and then you roll the patient onto it. You'll see in the demonstration of a log roll here in a moment, which is the most efficient way to do this, or get the patient onto a blanket. And then you'll just simply pull the patient as if they were on a sled behind you. Here's the arm-to-arm drag, or I think another name for it is a one-person incline drag. This is where you will stand behind your patient, place your arms up underneath the patient's armpits, and then from the back, grasp the patient's forearms. And then you will lift up and drag them. Their feet and their hips will be still on the ground as you drag them backwards. And this does offer a little bit of protection because you're kind of cradling the patient's head right here in your chest and between your shoulders. The firefighter drag. This is one of those ones that it's good for consideration. But you would tie your patient's wrists together with them laying supine or on their back, as you see in this picture. And then you would straddle them on your hands and knees, put their tied hands over your neck so that the tie and their hands are behind your neck. And then you would actually crawl across the floor with the patient kind of somewhat dangling underneath you. Emergency drags from vehicles. Remember, cardiac arrest or other life-threatening situations where the patient has to get out of that car now, not later. One rescuer, similar to the arm grab, you'll grasp the patient under the arms, cradle their head between your arms in this manner so that you're kind of protecting that cervical spine. And when you do this movement without doing that, their head will bobble back and forth, and that creates potential for further injury. And then you'll pull the patient out and away from the vehicle to a safe distance and gently lay them on the ground. Don't just let go, because their head will smack the concrete, and I have seen that happen before, and that's never a good thing. And then also you can do the same maneuver with 2 or more rescuers. One of those rescuers' primary job is going to be protecting their head from that lateral movement, where the other 1 or 2 people will scoop under the arms, and then an additional personnel will scoop underneath their knees or grab their hips with their waistline and pick up and move. You can utilize, when you have multiple responders, a long spine board or backboard if time permits. It's a little bit more lengthy, but the biggest advantage to that is it gives you handles and a rigid support system to actually carry that patient from point A to point B, especially for unconscious patients or patients who can't support their own weight anymore or help you. I like to use the term of going wet noodle on you. If you've ever picked up a truly unconscious patient, it's literally like trying to pick up a giant wet noodle, and they do not conform to whatever you're trying to hold on to. So backboards are very useful in that manner. For non-ambulatory patients, this one works better if they are conscious and they can kind of support their own head. If they're unconscious, you're going to want to revert back to this method, the 2-person extremity carry. But if they're conscious, they can support their own airway and kind of stay upright. The 2-person seat carry or cradle. You can see here in the left side of the picture where you're basically, the 2 rescuers are creating a cradle with their arms and interlocking their hands and wrists together. And then you place your patient in that in a seat-like fashion. Here's a 1-person cradle in the arms, pretty self-explanatory. This is pretty labor-intensive as well, especially going from the ground, standing up. Works better, as you can see here on the bottom of the slide, works better for smaller individuals or children. 2-person chair carry. So all ambulances nowadays have what is called the stair chair. which is basically, it's a commercial version of this that typically has some kind of form of tracks for helping you manage or mitigate a flight of stairs that helps you roll up and down the stairs. This is just a precursor or predecessor to that, where you use like an office chair or some kind of sturdy framed chair to where you can pick the patient up and carry them a longer distance or up or downstairs if you needed to. And there's a bullet point here at the bottom. The rescuer one gives command to lift and walk away. And same thing, I prefer personally to always have the person that's closest to the patient's head. Part of this also, if the patient is conscious, it kind of keeps them involved in the movement. Whoever's closest to their head, there's kind of like a personal connection there. And it helps with communication a little bit, I feel. The back strap carry, or pack strap carry, it's also on your back. You put your back to the patient, and as they are standing, you'll grab the patient's wrists and cross their arms over your chest, and then pull the patient onto your back by bending forward to lift the patient, and then you stand all the way up and walk away. So we have the direct ground lift. This is used to move a patient who is on the ground or floor to an ambulance stretcher. We should use this really only for patients who haven't sustained any kind of traumatic injury. And the steps for performing this, we don't have the skill drill on this PowerPoint, but we will go over that in our live practicals in the classroom. So now transferring a patient from the bed to a stretcher. We're going to place the stretcher right next to the bed, preferably pressed up against the bed. Loosen the bottom sheet underneath the patient, or log roll the patient onto a blanket. And you'll see that here in just a second. You will reach across the patient or across the stretcher and grasp the sheet and blanket firmly at the patient's head, chest, hips, and knees, and then slide the patient over. Sometimes it helps to have the stretcher slightly lower than the bed itself, so that you're not creating a lip that the patient will run into and get caught on. Okay, so this is an example of the log roll. You can see here they have the patient on the bed and they have a sheet. They're going to log roll the patient to one side, stuff the sheet up underneath the patient about halfway or half of the sheet, lay them back onto their back, log roll the opposite direction, and then you can grab the edges of that sheet and pull it the rest of the way through. And now you have a sheet cradle that you can actually, 3 to 4, sometimes 2, depending on how busy the hospital is. You can actually lift your patient up and move them across onto your stretcher. It is very beneficial on this if you have 3 providers or personnel, that third person should support the head. If you pick the patient up in a sheet and move them without supporting their head's just going to drop off the end of that sheet, and that can cause some injury or discomfort there. Here's a one-person walking assist. That's also pretty self-explanatory, but you can help a patient stand, someone that might have a lower extremity injury or a hip injury, something like that. You'll have the patient place one of their arms over your neck, and then you hold onto the patient's wrist with your free hand, wrap that around their waist, and you kind of give them some additional support as you assist them in walking to an area. Here's a 2-person walking assist. This is more useful for patients who truly can't bear any weight at all on an extremity. And this is where the 2 rescuers are completely supporting the vast majority of that patient's weight, if not all. Just to go back real quick, those are more movement techniques to where, except for the log roll and the sheet drag, where the patient just needs to move now. We don't have time to wait for a stretcher to come over here and get that all set up. We just need to get the patient up and out of this current situation, and then we'll lay them back down or set them back down. So now we can talk about real patient movement. We have wheeled ambulance stretchers. This in Western North Carolina is the Stryker stretcher. This is a power unit. This is kind of your mainstay that you'll see around Western North and South Carolina nowadays. Predecessors to this were the manual strikers. There's still a few of those where it takes 2 people to actually physically lift the stretcher up and down. We also had the Furno manual stretchers, which were very flimsy looking. They could support a lot of weight, but they were made out of galvanized tubular or aluminum type frame material. And that had this scissor lift like you can see here in this picture with a mechanical latch release where 2 people or more people would actually have to lift the patient up and down. These power stretchers have hydraulic motors that actually actuate a hydraulic cylinder in that scissor lift and can lift the patients up and down for you. Unfortunately, there is not at least that I'm aware of, a mechanical or power lift stretcher for bariatric patients. So that still requires 4 to 6 or more individuals to actually lift that stretcher up if need be. So stretchers can be rolled or carried. I would really say these power stretchers, if you're carrying them across a type of terrain, anything other than concrete or asphalt, are really going to need at least 4 people to carry them. They get kind of cumbersome in pea, gravel, sand, wet soil, things like that. They're very top heavy. So you have to be careful if you're moving on anything other than a smooth concrete floor. They have a tendency, one of those tiny little 6-inch wheels down there or 4-inch wheels will catch a pebble or stone, and if they're fully extended to their true height, they have a tendency to topple over. Power stretchers have become kind of the commonplace, most commonly used devices for EMS. This is how we move our patients in the back of the ambulance, how we secure them within the ambulance and keep them safe. It saves a lot of back injuries and other injuries to providers, and it also saves a lot of injuries to the patient themselves. We can very specifically select the height at which we need these power stretchers to be raised or lowered to. And then also they come with safe patient securing straps, and we really do want to utilize all of those straps on every patient. A lot of agencies now have it in their SOGs that you have to use the 5-point safety straps, which is really important due to the fact that in a hard braking or a collision with the ambulance, without those straps, there is a potential for the patient to slide off of the stretcher and crash into the cab, the back side of the cab of the ambulance. So those over the shoulder straps and then the 3 or 4 torso and leg straps need to be utilized at all times. We have portable stretchers. Most ambulances have some variation of this on them. This is a very lightweight type of stretcher that is often used in mass casualty incidents or just very tight places. A lot of mobile homes have very narrow hallways that a stretcher won't make it down, or they have curves, doorways that the bend is too tight. So these are useful tools to be able to move a patient for a short to moderate distance to where they can be transferred onto an actual transport stretcher. They're typically very light. You can see in this picture, this one, it folds in half, so it's easily compactable for storage. And it's also very easy to clean as well. Here's a picture of the stair chair that I mentioned a moment ago. As you can see on the back side of this chair, there's a set of what looks like kind of like tank tracks. When these are locked into the engaged position, they act as a braking movement system to where you can actually bring the chair down a flight of stairs at a controlled rate of speed. They have down here by the feet or in the front of it, there's telescoping handles that come out for a provider to stand below the chair on a set of stairs and kind of help brake it from falling down the stairs. And then you have handles behind where the patient's head would be for different angles to do the same thing. Typically, these will have 3 sets of securing straps. You have 2 shoulder straps that are typically configured in a crisscross pattern across the patient's chest, and then you'll have 1 set of straps for the legs to secure the lower legs to the chair as well. Immobilization for patients who have neck and back injuries. Now we're moving towards a spinal movement restriction method as opposed to a full spinal immobilization. We still have to know how to use long spine boards and other immobilization devices. But these are used to assist in lifting patients and immobilizing lower extremities. Long backboards are for moving patients who have experienced some type of trauma. Like I mentioned before, they also give you multiple handles to be able to pick that patient up and move them more easily. They're not really used in long-term movement anymore. In emergency situations, if you have to move a patient and there's no movement devices available, some recommendations or suggestions: you could use some wide and sturdy planks or boards, a door, ironing boards, small folding tables or sturdy folding tables, lawn chair recliners. If you're near the beach, you could probably use a surfboard, or in the mountains, you could use a snowboard. Although with snowboards, keep in mind they do have those blades on the sides, which can be rather sharp as well. There's a long spine board. Picture on the right side of your screen has a set of what's known as spider straps. These are Velcro straps that enable you to secure the patient in multiple places very quickly, as opposed to using the 3 9-foot straps, which really don't secure a patient adequately, and it allows them to shift while being moved. They are typically made of plastic or some type of fiberglass or a composite material. If you are moving the patient any kind of distance, they need to be secured with the straps. And in addition to that, if you're going to secure them with straps, their head needs to be secured as well so that they don't get turned into a whiplash scenario. If the patient has sustained back or neck injuries, the head should still be immobilized, or the head should be immobilized if they're being secured to the board. Short backboard devices. These are used to immobilize the head and spine of patients who are found in a sitting position who do not have critically life-threatening injuries. If this is a patient that needs to be extricated from a vehicle or from a situation immediately, these take time to apply, and they should not be used there. If there's some kind of airway compromise or something that you just cannot gain access to that patient, it needs to be foregone, and they need to be moved out. If this is a somewhat stable situation with a high index of suspicion on that patient, go ahead and use these, because you want to prevent further injury from the patient. The picture on the top there is what's known as a KED. This is a Kendrick's extrication device. There are other manufacturers other than Kendrick's that make devices similar to this, but this is a semi-rigid device that is designed to wrap around the patient with multiple straps and buckles. The one on the bottom is known as a short spine board or a backboard, and it is applied to the back of a patient utilizing straps, and it is a rigid board, just like a long spine board, but it's just shorter. Here's an example of a scoop stretcher. These are great for patients who have probable hip injuries or pelvic injuries, where doing a log roll or rocking them back and forth would cause extreme pain and increased internal hemorrhage from those broken bones. It's also useful for moving the patients out of small places. Most of these scoop stretchers have a telescoping ability, so you can make them shorter or longer if you need to. And you can also use these in situations of spinal motion restriction if that has an index of suspicion there. And there's another example of a more modern scoop stretcher. Anytime a patient has sustained a traumatic injury, we need to consider the possibility of injury to the head, neck, or spine. anytime that there is a distracting injury that took a significant amount of blunt force or trauma, we need to also keep suspicion of head, neck, or spine injury in the back of our heads as well. So if we treat these improperly, this can lead to permanent damage or even paralysis. So we don't need to be jerking or yanking these patients around. They do have a pretty unique ability to self-splint with our muscles, but we still don't want to be the cause of that further injury. All right, here's an example of some C-collars or cervical collars. These in the picture are actually an older version that you may still see lying around in some fire trucks or ambulances, but most of your cervical collars nowadays are simply adult or pediatric sizes, and they are adjustable. These were specifically made like one size fits this person, this size fits this person, and you could not adjust them, so you actually had to select the size of the collar that you're going to be utilizing. But these are not spinal immobilization devices. They are reminders to the patient that to not move their head. So if the patient wants to and is wearing one of these collars, they can still look to the left or right, move their head up and down, and it's not going to prevent that movement. So when I apply a C-collar or a cervical collar, I'll usually advise the patient, look, this is not going to stop you from moving your head. This is just a reminder. It's a little uncomfortable, but this is a reminder that you have some kind of injury that we don't want you to be whipping your head left and right on. So just remember not to move your head. And there's also many different manufacturers and styles and things like that. This orange one here at the bottom of the screen is a foam rubber, or a foam that's encased in a type of rubber that would be more like a therapeutic type of collar as opposed to emergency services. So if you're going to put the patient on a backboard, or there's a reason to suspect some kind of traumatic injury that requires spinal movement restriction, the collar should be placed onto the patient prior to any other immobilization devices like a backboard or a short spine board or KED. So first we want to stabilize the head and neck. We don't want to jostle or push the head and neck around unnecessarily. And then we will insert the back of the collar, as you can see in frame B of this image. We'll slide that flat piece of the collar back behind the patient's head and then wrap the front around so that the cup for the chin aligns in the middle. We don't want to twist their head out of alignment. And then secure that collar with the Velcro strap that's provided. So remember, placing a patient on a backboard is not our primary objective or goal, but you may need to be able to or be requested to assist EMS with that task. So knowing how to do it is pretty important. So patients should not be transported on a backboard. Excuse me, or patients who should not be transported on a backboard. Anyone who has sustained spinal trauma in a motor vehicle. Wait a minute. Did I just? Okay, Kevin, can we go back to the beginning of this slide, and I'll just start this slide over again. So when considering moving a patient on a backboard, typically this is going to be a very short-term movement, and the judgment on that is going to be done by the EMS providers, whether it be an advanced EMT basic, or a paramedic. So this should not be our primary goal when we're treating our patients, to actually secure them and prepare them for transport to the hospital. But patients that we can consider that should be transported on a backboard would include any patient who has sustained a spinal trauma in a motor vehicle crash or a fall, or any major injuries to the trunk, anyone who is altered that we can't rely on what they're telling us about their condition or their injuries. But if you do suspect a patient has a spinal injury, move the patient as a unit, talk to your team, transport the patient face up, or what is better known as supine. There's really no good reason to be transporting a patient face down. I have heard of a couple scenarios where that was the only way it could be done, but if there was another way, it would have been better to not. But if that's the situation, that's what you got to do. Keep the patient's head and neck in a neutral position. We don't want to put them in a constant state of stress or strain. And be sure that all rescuers understand what is going to happen or what needs to be done before we do it. And then remember, the person at the head controls the movement of the body. So for log rolling, this is the primary technique that is used to move the patient onto a long spine board, or when we're getting a drag sheet up underneath the patient. And it really does need 4 people. It can be done with 2 or 3, but 4 is ideal. The movement technique of choice is in all patients with a suspected spinal injury, even if we're log rolling them onto a sheet to get them up off the ground. So the sequence of events for moving a patient has 2 commands. First, a question: is everybody ready? And then an order for the movement, so that the patient moves as a unit. And then keep, to the best of your capabilities, keep the patient's head in a neutral position at all times. Here's an example of a straddle lift carry. This is very useful in tight places where you can't get beside the patient. However many rescuers you have, there's 3 in this picture, would straddle over the patient and lift the patient straight up, while another rescuer will slide the backboard up underneath the patient. And then if you're going the method of strapping the patient down to the backboard for a little bit longer of a carry, you would follow that procedure. If you're just moving a very short distance, then you would just lift the backboard and move them. Every patient who is on a backboard for somewhat moderate of a distance should be strapped down to prevent them from sliding or slipping or even falling off of the board. You have you have 6. I'll start that slide over if you don't mind, Kevin. So every patient that is going to be moved for some distance on a backboard needs to be secured via straps, whether this be 9-foot straps or spider straps. It doesn't really matter. It just prevents them from slipping or sliding up or down or from side to side and causing the potential for them to fall off of that board. Once the patient is centered on the board, secure the upper torso with the straps first, and then the pelvis, and then the legs. If we go the other way, legs first, there's always the potential that they could slide off of the board, causing that upper body to contort the leg, causing lower extremity injuries. Foam blocks on either side of the patient's head to help prevent that lateral movement, and then secured with tape or commercial securing straps like you see here in this picture. Also remember, if you are going to move your patient on a backboard for an extended distance, to pad the voids. One way that you can help mitigate that pressure that it causes on their back is to put a folded blanket under the entire length of the board to kind of create some cushion or insulation. And then the voids, what I mean by that is the small of their back, underneath their neck, in between their shoulder blades, knees, any kind of place that's going to be suspended and cause extra pressure. So remember, we have a few general guidelines for moving patients. We don't want to do any further harm to our patient. We only want to move them when necessary. We want to move them as little as possible. I could add as gently as possible as well. Move the patient as an entire patient. Use proper lifting and moving techniques. Remember, not only if we're not using proper techniques, not only are we potentially going to cause injury to ourselves, we're potentially going to cause injury or further injury to our patient when we drop them. Have one rescuer, preferably at the head of the patient, to give the commands on when to move the patient. Unconscious patients cannot help you, so they will be more difficult to move. But if they have not sustained a significant trauma or suspected trauma, they should be placed in the recovery position until you have resources available to manage that patient. If the patient is on the floor or the ground during an emergency situation, you may have to drag them away from the space using one of the techniques that we just covered in this chapter. And remember, trying to lift or carry a patient in an emergency situation like that by yourself creates a lot of stress and strain on you as the provider and increases the probability of injury to yourself. Try to avoid lifting or moving a patient that you suspect has a spinal injury until you have enough resources available. Again, going back to that life over limb, if you're having to move them out of a fire or some kind of imminent peril like that, you may have to move them even though they might have a spinal injury. Remember that it's commonplace now for us to use EMS to use wheeled ambulance stretchers. We have portable stretchers, stair chairs, long spine boards, short spine boards, and scoop stretchers available on ambulances for short-term movement of victims to that transport stretcher. Log rolling is the primary way to get a supine patient loaded up off of the floor onto a stretcher, whether it be with a backboard, scoop stretcher, or a sheet. And then once the patient has been secured to a backboard, we then need to secure their head using head blocks to immobilize and prevent that whiplash, that lateral movement of the patient. All right, that's it that we have for this chapter. Like I said in the beginning, write down any questions or notes that you want to review or have answered during our classroom session. Remember, we will be having tests, periodic tests on all this material, and we hopefully will have plenty of time in our classroom sessions to practice all of these in real life. So let's go ahead and do our review questions, and we'll see you on the next chapter. As an EMR, you might injure your back even if it is straight if you, which of these following options? The answer is A, lift with your back bent forward at the hips. So you're putting yourself out of center of gravity and you're using those smaller, weaker muscles. Patients who should be transported on a backboard include any patient who, which of the following would you choose? The answer is E, a little trick question there, has sustained major injury to the trunk. Which of the following is true about head immobilization? The answer is B, can be achieved using head blocks and or towel rolls or rolled up towels.